So there we are. So I'm talking from Sydney, but most of my clinical work I did when I was based in New Zealand and formed the Cardiac Inherited Disease Group. And really what I saw over my 22 years or so in New Zealand was how clinical practice has changed so remarkably. And I think this is probably what you're going to see in India. And I want to talk a little bit about what's going to happen over the next 20 years. So my focus, although it's arrhythmia clinic of the future, it's really more about the inherited arrhythmia clinic of the future, because that's really what's kept me busy, certainly over the last 15 years. We're talking about all the cardiac inherited disease, because after all, these are the things that can cause sudden death, syncope, cardiac arrest in children and youth. And we have the electrical type, we have the muscle types, and really arbitrarily dividing those up into just the electrical ones for the EP people and the muscular ones for the heart failure people really isn't how it goes, because really what we're about doing here is trying to keep people alive. When I started back in 1998, I started my arrhythmia clinic in New Zealand, and it's a weekly clinic, and I saw mostly SVTs, before and after ablation, the occasional pacemaker, and a little bit of syncope. I imagine you're swimming in those cases in India. But in 2000, I had my first two patients who were referred to me after their death. That's a boy there called Ben, who was 11 when he died playing hockey, and Danielle was 18 months, 21 months, when she died following a febrile convulsion. She'd had a febrile convulsion just a couple of weeks before, and then died suddenly at home. And the family came to see me and wanted to know why this had happened. Now, 2000, this was just a few years after the three commonest genes for long QT syndrome had been discovered. And in 2001, I wanted to try to start doing genetic testing, and I teamed up with Mark Rees on the bottom there on the right as a molecular geneticist, John French at the top right, an adult cardiologist, and Jackie Crawford, a pacemaker tech, cardiac physiologist, and we formed the Cardiac Inherited Disease Group. And there you see me with my son George, who is now 22 and particularly tall. Ben, we found by sourcing DNA from his Guthrie card, had died from long QT type 1. And so this was the first time in the world that preserved DNA had found a cause of death related to channelopathies using the Guthrie card. And this was in New Zealand. The Guthrie cards are stored for many, many years. And so we started sequencing those, and people kept coming to my clinic, and sometimes 3 decades, deaths from 3 decades previously, we were finding an answer. And I managed to get some money. We formed our little group. There's our CIDG, 4 people in the group. And we did a population-based study of sudden death, getting together with the National Forensic Service. And we did a molecular autopsy on all the unexplained deaths. And combining that with investigating family members, we found that 30% of 1 to 40-year-olds had an inherited heart condition. And so in 2008, New Zealand was by far and away the first country in the world to have state-funded the molecular autopsy. And the forensic pathologist was sitting firmly within our cardiac inherited disease group. In 2010, a genetic counselor joined full-time onto our panel, and we had regular multidisciplinary team meetings. We had regional coordinators now in 2012 from 2 other regions across New Zealand, and we had a clinical trainee who joined us, Catherine Waddell Smith. And while she was working with us, she helped move the cardiac inherited disease service actually into the hospital. And by the regional coordinators being part of the inpatient management, they started to detect inherited heart disease amongst adults who'd were sitting on the ward with their non-coronary disease, their dilated cardiomyopathy or their syncope. And by just taking a good family history, we found we were able to raise the diagnostic rate of inherited conditions from 8% up to 32%. But getting back to our clinic, the nature of the cardiac genetic clinic in 2000 was basically a child who presented mostly with a symptom, and there was one doctor, who was me. But in 2001, we now had two different clinics. We had John, who was running his hypertrophic cardiomyopathy clinics, and myself running syncope, sudden death clinics, coordinated by Jackie. By 2016, we had quite a team of people running conjoint clinics. We had an adult cardiologist and myself in the same room, and all of these people collaborating with this clinic. Then in 2019, I moved over from New Zealand to take up a position in Sydney. And I work now closely with Dr. Christian Turner, who's set up an inherited arrhythmia clinic. And this has come recently to the public eye following our work looking at the relationship of syncope to ventricular arrhythmia and sudden death. In fact, we identified through an international collaborative study 22 children who'd died suddenly or had a syncopal episode related to inherited heart conditions, mostly during video gaming, particularly the war game type games. But again, getting back to how we're going to model our clinics for now and for the future, if we're going to design an inherited arrhythmia service, you must first have an ethos, you must have a team and a plan. Our ethos is to detect, protect, and enable. Detect people with inherited heart conditions, protect them from sudden death, and enable them to get back to their normal activities as far as is possible. You need to form a team, and there they are, and you need a plan. And our plan was a simple one. We had a central coordinator, and if any practitioner from any walk of medicine felt that they had a patient who might have an inherited heart condition, they simply had to refer to this one email address or this one phone number from anywhere in New Zealand. We designed an infrastructure with a registry, database, secretarial support, and links to the university. And through having these regular meetings with colleagues across the country, we developed algorithmic protocols. For example, this one for the investigation of cardiac arrest once coronary artery disease or myocarditis had been excluded. And by developing this protocol and then people coming through that, going into a national registry, we soon started to find some interesting information about what is actually causing these cardiac arrests in the community when it's not due to coronary artery disease and it's not due to congenital or myocarditis in children. And you can see there that the majority were due to long QT syndrome. And the younger you were, the more likely you were to have a channelopathy, and the older you were, the more likely it was to be a cardiomyopathy. That's in the blue there. Interestingly now, as our clinic grows, one of the things that's changing, increasing our diagnostic rate is the use of imaging, particularly in people who have unexplained or difficult to explain cardiac arrest. This was a study from Boston, showed that MRI imaging was essential in the investigation of VF in children and youth. So now in our 2018 team, we have an imaging specialist who's joined the team. What we've noticed by having this team active since the early 2000s is that the nature of the presentations is changing. As we get better at screening families and identifying people in the community with long QT syndrome, we're protecting them. And we're seeing very few cardiac arrests now due to long QT syndrome, but CPVT is being presented more commonly as community resuscitation is getting more and more effective. When we looked at the recent 10 years in Sydney, those children that had survived a cardiac arrest and arrived in pediatric intensive care, CPVT was the commonest, and then a list of rather rare causes. And this is what we're going to see, I think. Very little long QT syndrome in the future because we're good at screening it out. And we're going to see more and more rare things, unique things causing VF sudden death. So we will be co-managing our patients with metabolic, endocrine, and other genetic conditions with other different specialties. But where should this clinic be if we're looking to the futures? Because, you know, hospitals are very frightening. You have grief to deal with, you have many investigations to do, and you have adult and pediatric cardiology specialists and also psychologists, genetic counselors, and so on. You have large families to meet and inform, complex dynamics in the clinic, sometimes with some parts of the family which don't necessarily get on with other parts. You have many professionals and you have large distances from home. So the typical outpatient clinic setting is not suitable. The ideal cardiac genetic clinic and the ideal inherited arrhythmia clinic would have many rooms. It wouldn't be too medicalized. You'd have plenty of time. You'd have a large room for family meetings. There'd be a play area for children, family friendly. You'd have well-organized, built-in flexibility with the team meeting up prior before the clinic. You'd have easy access to information about the whole family. You'd have a coordinator bringing all these informations in together for our MDT before the clinic. You'd have a hub and spoke model of care with a center guiding care, collaborating with regional cardiologists, geneticists, and other specialists. So it might look a bit like this sort of conglomeration of a play area, a meeting room, and comfortable areas to sit and deal with some difficult topics. Of course, you need a registry database, and it has to be a good one. Our one in New Zealand is a bespoke one with family drawing facility, and each of, you can just click on each family member and you bring up all the details, but there are commercially available systems that you can use. So what does the photo of an ideal clinic look like? Oh, well, it doesn't quite look like this, but this is really to show you the kind of camaraderie that is involved in this sort of thing. And in fact, we're all gathered there at a local pub from a family of a young man who died suddenly. We tried our best to find the cause of death. We never did find the cause of death. But this pub, this brewery now raises money for our cause. And it's a lovely annual event to go and celebrate this man's life and celebrate the money they're raising for us. It's quite an emotional thing to get involved with the investigation of sudden death. So there's our team. We're now identifying thousands of people with inherited heart conditions. And that's now. So what about in 2031? Well, now we're going to have gene therapies. We're going to have screening. I imagine that ECG screening will now have come of age. We'll have phenotype. People bringing their own phenotype with you, might even bring in their own genetic diagnosis with you. So it's really interesting. I mean, I think that people will come into the clinic, as they already are, with the diagnosis of SVT from their Apple Watch. They'll come with their ECG phenotype. The doctor, my phone says I've got long QT syndrome. We're going to see more and more of this. And now we're seeing that Mike Ackerman's work in the Mayo Clinic at the simple Cardia device there is able to detect long QT syndrome even more reliably than your average doctor. So patients can buy one of these, make their diagnosis, and turn up at your door. And already in the States and across the world, you can order your own genetic profile, and these will become increasingly more detailed. Genetic health diseases can help you diagnose your disease. So patients are already coming to our clinic with their genotype and asking what it means. I'll give it to you straight. This disease is almost impossible to pronounce. So we're going to have to be really clued up and partnered with our genetic colleagues. It won't be doctors and mainstream medicine that leads the genotype phenotype development. It's going to be industry and the lay public, because they want it, they're going to buy it. If it's commercially available, they will do. So at the moment, we have many ways that we can protect people once we diagnose their condition: ICDs, keyhole surgery, beta blockers, but new therapies are coming. We're going to have gene therapies. Long QT syndrome gene therapy is probably a decade away. CPVT is probably a little bit closer. So it's coming. All of these advances, more than 2,000 publications a year on gene therapy in PubMed. So the future clinic will be defining which gene therapy is given to whom in our patients with inherited arrhythmias. And we're going to need to have these people in our registry so that when the therapy becomes available, we can give them a call and offer them this new therapy. So 1998, inherited arrhythmia clinics didn't exist. In 2008, they were still pretty rare. 2018, most large centers have one. 2028, family-orientated inherited arrhythmia clinics are the norm. Most new patients are found through genetic and population screening and refer themselves from genetic tests and devices. And in 2038, well, maybe it's not relevant because planet Earth is no longer habitable, but if you're not a cynic like me, then perhaps gene therapies for acquired and inherited heart disease are commonplace, and the cardiac genetic clinics manage the administration and follow-up of these. But we'll only learn about what genes do if we study the phenotype properly, and how genetic variants correlate with phenotype requires detail of both. And this can only be achieved by large-scale clinical genetic registries. We've got more than 5,000 in our registry now in New Zealand. And the future meaningful progress of cardiac genetics will depend on multidisciplinary, translational, international, multi-ethnic, collaborative, consent-based cardiac genetic registries. Managed to get through that without a stutter, but that's what we have to aim for. But will genetic diagnosis and gene therapy be bought online like any other commodity? It's going to be really hard to keep up. We don't know what's coming, but we're going to need to try to keep up so we can stop our patients going down the various dark holes that such therapy might open. Humans are losing themselves to technology. There's an old Maori proverb which says, what is the most important thing in the world? It is the people, it is the people, it is the people. It's going to be hard to keep up with the genetics. So let's hope we don't lose our humanity. Thanks very much for listening. It's been a real pleasure, and I wish you all the best for the rest of your conference. Bye for now.